So, justice and the high cost of health. 1. Everyone agrees that the United States now spends too much on healthcare. Medical services accounted for 14% of our gross domestic product in 1991. France and Germany spent 9%, and Japan and Britain 8%, and economists predict that without reform, medical expenses will grow to 18% by the year 2000. But how much should a nation like ours spend on its citizens' health? How do we know that other nations are not spending too little, rather than that we are spending too much? Most people also agree that healthcare is unjustly distributed in America. 40 million Americans have grossly inadequate medical coverage or none at all, and many who now have adequate insurance will lose it because they will lose their jobs or develop a disease or condition that makes them uninsurable. In all, without reform, a quarter of all Americans will be without health insurance for some period during the next 5 years. But how much health care should a decent society make available for everyone? We can't provide everyone with the medical care that the richest among us can buy for themselves. How do we decide what lesser level of healthcare justice demands even the poorest should have? The healthcare plan that President Clinton presented to Congress in 1993, but was never adopted, would have instituted a form of healthcare rationing. It provided a basic package of healthcare that would be guaranteed to almost everyone. The plan specified some components of this basic package in considerable detail. The package included, for example, a comprehensive schedule of immunization for infants and children, routine screening, and physical examinations at different intervals for different age groups, and mammograms to detect breast cancer for women every 2 years starting at age 50. The plan also specifically excluded some kinds of treatment from the basic package altogether, most cosmetic surgery, for example. The plan's most important rationing provision, however, was not detailed but extremely abstract. It provided that medical treatment be part of the basic package only if it was necessary and appropriate, and it would have created a national health board charged with the responsibility of determining what kinds of treatment were necessary and appropriate and in what circumstances. That board would have had to decide, for example, whether bone marrow transplants or other experimental forms of treatment were necessary and appropriate for particular diseases. It would have had to determine whether most people could have such expensive procedures when doctors told them that was their only chance, slim though it might be. How should an agency charged with such a responsibility make such decisions? When should expensive magnetic resonance imaging be provided to those who cannot afford it on their own? Should speculative bowel and liver transplants ever be provided? If so, to which patients suffering from which diseases? If a nation cannot buy all the tests and treatment that its citizens might want or need, how should it decide, as a nation, how much it should spend collectively and on each citizen? Some critics deny that any such rationing of health care is really necessary. They argue that if the waste and greed in the American health care system were eliminated, we could save enough money to give men and women all the medical treatment that could benefit them. But though administrative expenses account for a significant part of hospital costs, according to a New England Journal of Medicine study, administrative costs were 25% of hospital costs in 1990. See Eric Ekholm study links paperwork to 25% of hospital costs. And American doctors' salaries are extremely large by other nations' standards. The average medical salary in the United States in 1992 was over $160,000. Salary varies dramatically by medical specialty. The average salary of a cardiovascular surgeon was $574 $1,769. That of a family practitioner, $119,186 $100. See health plan would hurt most of the doctors who make the most. The greatest contribution to the rise in medical costs in recent decades has been the availability of new, high-tech means of diagnosis like magnetic resonance imaging and new and very expensive techniques like organ transplants and, on the horizon, monoclonal antibody treatment for cancer. America is not paying all that much more for the medicine it formerly bought more cheaply. Rather, it now has so much more medicine to buy. Many politicians and some doctors say that much of the new technology is unnecessary or wasteful. They do not mean that it provides no benefit at all. They mean that its benefit is too limited to justify its cost. And this is an argument for rationing, not an argument that rationing is unnecessary. There is an emerging consensus among doctors that routine mammograms for women under 50, which are expensive, do not save many women's lives. But they do save some. See Ginacolata mammogram guideline is dropped. Hair transplants that rarely work do work rarely, so we cannot defend the rationing decisions that any health care plan would make us as simply avoiding waste. We cannot avoid the question of justice. What is appropriate medical care depends on what it would be unfair to withhold on the grounds that it costs too much. 2. For millennia, doctors have paid lip service, at least, to an ideal of justice in medicine which I shall call the rescue principle. It has two connected parts. The first holds that life and health are, as René Descartes put it, chief among all goods. Everything else is of lesser importance and must be sacrificed for them. The second insists that healthcare must be distributed on grounds of equality, that even in a society in which wealth is very unequal and equality is otherwise scorned, no one must be denied the medical care he needs just because he is too poor to afford it. These are understandable, even noble, ideals. They are grounded in a shared human understanding of the horror of pain, and beyond that, of the indispensability of life and health to everything else we do. The rescue principle is so ancient, so intuitively attractive, and so widely supported in political rhetoric that it might easily be thought to supply the right standard for answering questions about rationing. In fact, however, the rescue principle is almost wholly useless for that purpose, and the assumption that it sets the proper standard for healthcare reform has done more harm than good. The principle does offer an answer to the question of how much America should spend on healthcare overall. It says we should spend all we can until the next dollar would buy no gain in health or life expectancy at all. No sane society would try to meet that standard any more than a sane person would organize his life on that principle. In past centuries, however, there was not so huge a gap between the rhetoric of the rescue principle and what it was medically possible for a community to do. But now that science has created so many vastly expensive forms of medical care, it is preposterous that a community should treat longer life as a good that it must provide at any cost, even one that would make the longer lives of its people lives barely worth living. So the rescue principle's answer to the question of how much a society should spend on healthcare overall must be rejected as incredible. Once that answer is rejected, the principle has no second best or fallback level of advice. It simply is silent. That is worse than unhelpful, because it encourages the idea that justice has nothing to say about how much a society should spend on healthcare, as against other goods like education or controlling crime or material prosperity or the arts. The rescue principle does have something helpful, though negative, to say about the other question of justice, which is how healthcare should be distributed. It says that if rationing is necessary, it should not be done, as it now largely is in the United States, on the basis of money. But we need more positive advice. What should the basis of rationing be? The egalitarian impulse of the principle suggests that medical care should be distributed according to need. But what does that mean? How is need to be measured? Does someone need an operation that might save his life but is highly unlikely to do so? Is someone's need for life-saving treatment affected by the quality his life would have if the treatment was successful? Does the age of the patient matter? Does someone need or deserve treatment less at 70 than at a younger age? Why? How should we balance the need of many people for relief from pain or incapacity against the need of fewer people for life-saving care? At one point, the procedures of an Oregon commission appointed to establish medical priorities ranked tooth capping ahead of appendectomy, because so many teeth can be capped for the price of one operation. Why was that so clearly a mistake? We need a different, more helpful statement of ideal justice in healthcare, and we should start by noticing one problem that seems to make reform mandatory. Why does America spend so much more than other nations, on medicine? In large part because individual decisions about how much healthcare to buy are made by patient and doctor, but paid for by a third party, the insurance company, so that those who make the decisions have no direct incentive to save money. Insurance premiums are tax deductible, moreover, and an employer's contribution is not treated as part of the employee's taxable income. So health insurance makes patients insensitive to cost at the moment of decision, and the real price of that insurance is subsidized by the nation. People would probably spend less on their own or their family's care if they had to pay the actual cost themselves, at the expense of other goods and opportunities they might also want or want their families to have. Of course, in the long run, most people do pay the true costs of their healthcare, but they do so indirectly and unwisely because employer contributions and tax funds could be used to buy what they would choose to have if they made the choice themselves. Sovereign Virtue by Ronald Dworkin. Better schools for their children, for example, or economic investments and programs that would improve America's competitiveness and give them greater job security. Our medical expenditures are therefore irrational. The system makes choices for people that they would not make for themselves, and the result is that our collective expenditures are too high measured as they should be, by how much care we really want taken together at the price we really want to pay. Conservative economists seize on this fact. They say we should create a free market in healthcare by removing all tax benefits and subsidies so that people can have only the care they can afford. While that is, of course, an unacceptable solution, it is important to see why. It is unacceptable for three reasons. First, wealth is so unfairly distributed in America that many people would be unable to buy any substantial health insurance at market rates. Second, most people have very inadequate information about health risks and medical technology. They do not know what the risk of breast cancer is before the age of 50, for example, or how many years having routine mammography before that age would add to their life expectancy. Third, in a non-regulated market, insurance companies would charge some people higher premium rates because there were greater health risks, as indeed many insurance companies now do, so that people with a poor health history, or who were members of ethnic groups particularly susceptible to certain diseases, or who lived in areas where the risk of violent injury was greater, would be charged prohibitive rates. This analysis points to a more satisfactory ideal of justice in healthcare, the prudent insurance ideal. We should allocate resources between health and other social needs, and between different patients who need treatment, by trying to imagine what healthcare would be like if it were left to a free and unsubsidized market, and if the three deficiencies I have just described were somehow corrected. So try to imagine that America is transformed in three ways. Suppose first that the distribution of wealth and income is as fair as it possibly can be. I won't. In my view, that means that the resources people can initially command in making their decisions about education, work, and investment are as nearly equal as possible. But you should imagine an economic distribution that is fair according to your own views, whatever these are. I shall assume, however, that on your views, as on mine, the wealth of everyone in a fair society would be much closer to the average than is true in America now. The great extremes between rich and poor that mark our economic life now would have largely disappeared. Second, imagine that America has also changed so that all the information that might be called state-of-the-art knowledge about the value and cost and side effects of particular medical procedures, everything, in other words, that good doctors know, is generally known by the public at large as well. Third, imagine that no one, including insurance companies, has any information available about how likely any particular person is to contract any particular disease or to suffer any particular kind of accident. No one would be in a position to say, of himself or anyone else, that that person is more or less likely to contract sickle cell anemia or diabetes, or to be the victim of violence in the street than anyone else. No, I'm reading a book. I am ignoring an important issue that my argument raises, but that I will not pursue here. Is it right, in the hypothetical exercise I am constructing, to exclude information relating risk of disease to voluntarily chosen behavior? Should insurance companies be in a position to charge cigarette smokers or mountain climbers higher premiums, for example? That seems reasonable. But if so, what counts as voluntary behavior? Should sexual behavior of a particular kind be treated as voluntary for this purpose? It would seem wrong for insurance companies to charge active male homosexuals higher premiums because they are considered more likely to contract AIDS. Is this because sexual preference is less under people's control than nicotine addiction? Or because the sacrifice in giving up sex is so much greater than that in giving up smoking? Sovereign Virtue by Ronald Dworkin. I already said it. The changes I am asking readers to imagine are very great, but they are not, I think, beyond the reach of the imagination. Now suppose that healthcare decisions in this transformed community are left simply to individual market decisions in as free a market as we can imagine, so that doctors and hospitals and drug companies are free to charge whatever they wish. Medical care is not provided by the government for anyone, nor are medical expenses or health insurance premiums tax deductible. There is no need to subsidize medical care in any such way, because people have enough resources to buy for themselves the medical care they decide is appropriate. What kind of healthcare institutions would actually develop in such a community? Would most people join health maintenance organizations that provided care by staff doctors at a relatively inexpensive rate? Would any substantial number choose more expensive insurance arrangements that allowed more freedom of choice in doctors or hospitals? Would the average plan or policy provide coverage for routine medical examinations or diagnostic screenings? What kind, how often, and at what age? How many plans or policies would provide, at appropriately high rates or premiums, experimental or very expensive or high-risk or low expected benefit procedures of different kinds? How much of its aggregate resources would the community devote to medical care through these various individual decisions? It is impossible to answer these questions with any precision. It does seem likely that even though the members of the imagined community would begin by making individual insurance decisions, they would soon develop, through these individual decisions, collective institutions and arrangements like cooperative insurance purchasing agencies or pools, because these would provide economic advantages in a free market among people of roughly equal wealth. The result of the process might very well be something functionally very close to that proposed in Clinton's plan. But we can nevertheless make two crucial claims about justice. First, whatever that transformed community actually spends on healthcare in the aggregate is the morally appropriate amount for it to spend. It could not be criticized on grounds of justice for spending either too much or too little. Second, however healthcare is distributed in that society is just for that society. Justice would not require providing healthcare for anyone that he or his family had not purchased. These claims follow directly from an extremely appealing assumption, that a just distribution is one that well-informed people create for themselves by individual choices, provided that the economic system and the distribution of wealth in the community in which these choices are made are themselves just. My claim needs minor qualification. Even in the imagined community, some paternalistic interference might be necessary to protect people from imprudent insurance decisions, particularly when they are young, and some constraints might be necessary to provide adequate resources for later generations. These important conclusions help us to decide what healthcare we should aim to provide for everyone in our own imperfect and unjust community. We can speculate about what kind of medical care and insurance it would be prudent for most Americans to buy for themselves if the changes I imagined had really taken place. And we can use those speculations as guidelines in deciding what justice requires now, in deciding, for example, which medical tests and procedures the National Health Board should decide are necessary and appropriate if the Health Security Act is passed. Consider a 25-year-old with average wealth and prospects and state-of-the-art knowledge of medicine. Suppose he can choose from a wide variety of possible arrangements to provide for the health care he might want under various contingencies over the course of his life. What arrangements would it be prudent for him to make? That is different from asking what any particular 25-year-old would in fact do, because many people, particularly when young, do not make prudent decisions. They do not, that is, make the decisions that best serve the plans, convictions, tastes, and preferences they would find, on reflection, that they already have. It is prudent, of course, to provide for change. Any prudent long-term insurance policy is written in general clauses rather than precise details of treatment, and is open to revision year by year. He might be tempted, initially, to buy insurance providing every form of treatment or care that might conceivably be beneficial for him under any circumstance. But he would soon realize that the cost of such widely ambitious insurance would be prohibitive. He would have nothing left for anything else, and decide that prudence required a much less comprehensive insurance program. Of course, what is prudent for someone depends on that person's own individual needs, tastes, personality, and preferences, but we can nevertheless make some judgments with confidence that they would fit the needs and preferences of most contemporary Americans. We can be confident, for example, about what medical insurance it would not be prudent for most people to buy, because some insurance would be a mistake no matter what happened in the future, including the worst outcome. It would be irrational for almost any 25-year-old to insure himself as to provide for life-sustaining treatment if he falls into a persistent vegetative state, for example. The substantial sum he would have to spend in insurance premiums year by year to provide that coverage would be much better used in other ways to enhance his actual conscious life. Even someone who lived only a few months after purchasing the insurance before he fell into a vegetative state would have made, in retrospect, a mistake, giving up resources that could have made his short remaining conscious life better in order to buy a longer unconscious state. We can enlarge this claim to include dementia as well as unconsciousness. It would not be prudent for almost anyone to purchase insurance providing for expensive medical intervention, even of a life-saving character, after he entered the late stages of Alzheimer's disease or other form of irreversible dementia. The money spent on premiums for such insurance would have been better spent, no matter what happens, in making life before dementia more worthwhile. Of course, most prudent people would want to buy insurance to provide custodial care in conditions of dignity and adequate comfort if they became demented. Providing for such care would be much less expensive than providing for life-saving treatment, for example, renal dialysis or an organ transplant if it were needed. See Ronald Dworkin, Life's Dominion, Chapter 9. Now consider a somewhat more controversial suggestion. In most developed countries, a major fraction of medical expense, over a quarter of Medicare payments in the United States, for example, is spent on people in the last 6 months of their lives. Of course, doctors do not always know whether a particular patient will die within a few months, no matter how much is spent on his care. But in many cases, sadly, they do know that he will. Most young people, on reflection, would not think it prudent to buy insurance that could keep them alive by expensive medical intervention for 4 or 5 months at the most if they had already lived into old age. They would think it wiser to spend what that insurance would cost on better health care earlier, or on education or training or investment that would provide greater benefit or, more important, security. Of course, most people would want to live those additional months if they did fall ill. Most people want to remain alive as long as possible, provided they remain conscious and alert and the pain is not too great. But prudent people would nevertheless not want to guarantee those additional months at the cost of sacrifices in their earlier, vigorous life, although, once again, they would certainly want insurance to provide the much less expensive care that would keep them as comfortable and as free of pain as possible. We can use these assumptions about what most people would think prudent for themselves, under fairer conditions than those we now have, as guides to the health care that justice demands everyone have now. If most prudent people would buy a certain level of medical coverage in a free market if they had average means, if nearly everyone would buy insurance covering ordinary medical care, hospitalization when necessary, prenatal and pediatric care, and regular checkups and other preventative medicine, for example, then the unfairness of our society is almost certainly the reason some people do not have such coverage now. A universal healthcare system should make sure, in all justice, that everyone does have it. On the other hand, if even under fair conditions, very few prudent people would want to insure themselves to a much higher level of coverage, if, as I said, very few people would insure to provide life-saving care when demented, or heroic and expensive treatment that could prolong their lives only by a few months, for instance, then it is a disservice to justice to force everyone to have such insurance through a mandatory scheme. Of course, any judgment about what most prudent people would do is subject to exceptions. Some people have special preferences and would make very different decisions from those that many other people would. Some people might think, even on reflection, that guaranteeing a few extra months of life at the end was worth great sacrifice earlier, for example. People with certain religious convictions might make that choice, for example. But it is worth noticing that even those Catholics and others who think that it is always wrong to refuse available life-prolonging treatment do not necessarily think that all possible sacrifices must be made in advance to ensure that very expensive life-prolonging treatment is available. Someone who thought it would be wrong, as a matter of religious principle, to decline an expensive and arduous operation that he could afford in order to extend his life a few months might nevertheless, with perfect consistency, think it prudent not to pay for the insurance over his lifetime that would enable him to afford it. He might think it more sensible to use the money that such insurance would cost to provide better medical treatment for himself or his family earlier, or better education, or some other goods or opportunities his convictions also deemed important. If so, then the prudent insurance test offers no reason why a national health scheme would make available for him what he would not have insured to provide for himself. But it seems fair to construct a mandatory coverage scheme on the basis of assumptions about what all but a small number of people would think appropriate, allowing those few who would be willing to spend more on special care to do so, if they can afford it, through supplemental insurance. If we substituted the prudent insurance approach for the rescue principle as our abstract ideal of justice in healthcare, we would therefore accept certain limits on universal coverage, and we would accept these not as compromises with justice, but as required by it. Expensive treatment for unconscious or demented or terminally ill patients would be relatively easy cases to decide if we adopted that approach. Other decisions would be more difficult to make. Sovereign Virtue by Ronald Dworkin. Including, for example, heart-wrenching decisions about the care of babies born so deformed or diseased that they are unlikely to live more than a few weeks, even with the most heroic and expensive medical intervention. A few years ago, doctors in Philadelphia separated newborn Siamese twins who shared a single heart, though the operation would certainly kill one baby and give the other only a 1 in 100 chance of surviving for long, and though the total cost was estimated to be $1 million. The twins' parents had no medical insurance, but Indiana, where they lived, paid $100 a day toward the cost, and the Philadelphia hospital absorbed the rest. The chief surgeon justified the procedure by appealing to the rescue principle. There has been a unanimous consensus, he said, that if it is possible to save one life, then it is worth doing this. Yes. Very interesting. But the different standard I am defending would probably have recommended against the operation. Suppose people of average wealth, when they marry, are offered the opportunity to buy one of two insurance policies. The first provides that if any of their children is born with a life-threatening defect, neonatal treatment will be covered only if it offers a reasonable, say 25% chance of success, and the second, much more expensive, provides that such treatment will be guaranteed even if it offers only the barest hope. Most potential parents would decide, I believe, that it would be better for them and their families to buy the first policy and to use the premiums they would save each year to benefit their healthy children in other ways, to provide better routine medical care, or better housing, or better education, for example, even though they would be giving up the chance for a desperate gamble to save a defective child if there ever had one. Any public body charged with overseeing the distribution of health care would have to decide what medical procedures are necessary and appropriate, and thus should be part of a comprehensive package of benefits everyone is guaranteed. Some of these decisions would be particularly difficult. Deciding when very expensive diagnostic techniques or experimental organ transplants with a low chance of success are appropriate, for example. Such decisions must of course be based on the best and latest medical evidence, and must constantly be reviewed as that evidence changes. But they, too, should be guided by the standard of individual prudence. Would it make sense for someone to insure himself when young to guarantee a vastly expensive blood test which would improve the diagnosis of a heart attack by a very small percentage of accuracy if he should ever have doubtful symptoms of cardiac disease? Or to provide a risky, expensive, and probably ineffective bowel and liver transplant if doctors decided it would give him a small chance to live? The rescue principle insists that society provides such treatment whenever there is any chance, however remote, that it will save a life. The prudent insurance principle balances the anticipated value of medical treatment against other goods and risks. It supposes that people might think they lead better lives overall when they invest less in doubtful medicine and more in making life successful or enjoyable, or in protecting themselves against other risks, including economic ones, that might also blight their lives. An agency might well decide that while prudent people would provide their family with the prenatal and well-child care that so many Americans lack, and would insure against serious medical risks at all stages of their lives by providing tested and reasonably effective treatment should they need it, they would forego heroic treatment of improbable value if they needed it in return for more certain benefits like education, housing, and economic security. Prudence individuelle. If so, then justice demands that a universal health scheme not provide such treatment. In summary, the prudent insurance test helps to answer both questions of justice I mentioned at the beginning. How much should America spend overall on its healthcare, and how should that healthcare be distributed among its citizens? The test asks what people would decide to spend on their own medical care as individuals if they were buying insurance under fair free market conditions, and it insists first that we as a nation should spend what individuals would spend collectively under those conditions, and second, that we should use that aggregate expenditure to make sure that all have now as individuals what they would have then. Of course, some of the decisions I have been discussing would be made differently by different people trying to apply the prudent insurance test. It is very important that any agency charged with those decisions should be made up of representatives of different groups that might be expected to make such judgments differently. It should have doctors and healthcare specialists, of course, but it should also have ordinary people of various ages drawn from different parts of the country and, if possible, different ways of life. Such an agency could draw on the experience of countries with single-payer government-run health services which have had systematically to ration healthcare. I'm sorry. In Britain, for example, doctors in the national health system have been forced to allocate scarce resources like renal dialysis machines and organs for transplant, and they have worked out informal guidelines that take into account a potential recipient's age, general health, life quality, and prospects, as well as prospects for adequate care by family or friends. Ah, je vais le virer, lui. Mais, ah. Voilà, bye bye. Though the supposed... J'ai lu ça? Ouais. Though this supposed cost-benefit test is different from the prudent insurance test, The decisions doctors have made under the former presumably reflect their judgments, guided by experience, about the relative value of different kinds of treatment at different ages and in different circumstances, and these are also judgments that a prudent insurer would be required to make. Merci, ouais. Bon courage, il est complètement fou, Comte, n'est-ce pas, Geoffrey? C'est une agrégative de l'année prochaine, Roman Study Corner. The prudent insurance test also makes plain why it is so important to consult public opinion before rationing decisions are made. Tu prends l'anglais aussi à l'oral ou pas? Ou une autre langue? Since rationing should reflect not just technical cost-benefit calculations but also the public's sense of priorities, consultation is essential. When Oregon sought to establish priorities in healthcare under Medicaid, it organized a series of town meetings and a parliament to discuss the matter, and though the meetings were criticized by some because they were attended by very few of the poor whose healthcare was being debated, the meetings were nevertheless valuable sources of information about what those who did participate thought would be prudent insurance decisions. Still, no matter how much information an agency seeking to apply the prudent insurance test is able to gather, its results must be provisional, open to revision on the basis of further evidence of public preference as well as of medical technology and experience. Clinton's failed healthcare plan would have allowed people covered by the plan to purchase supplemental health insurance at market prices, with no tax deduction or subsidy. That provision would have fitted the prudent insurance approach particularly well. The rescue principle might hold it unjust for anyone to buy better medical care than everyone can have, and that medical care outside a system of universal coverage should therefore be abolished or, as it is in Canada, seriously discouraged. But the prudent insurance approach begins in a different idea, that no one can complain, on grounds of justice, that he has less of something than someone else does, so long as he has all he would have if society were overall just. Suppose, for example, that if wealth were fairly distributed, no one, in view of the cost and the prospects, would prudently insure to provide a liver and bowel transplant for himself, even though it might conceivably one day save his life. If so, then justice does not require that such transplants be provided for everyone now, even when some people, unfairly rich, can buy them for themselves. See Ronald Dworkin, Justice in the Distribution of Health Care, in McGill Law Journal 38. If, after an agency has established a basic coverage package, a very substantial number of people of average income buy supplemental insurance, in spite of its expense, the basic package should be expanded. If most men of average wealth bought supplemental coverage providing yearly prostate examinations beginning at a younger age than the basic package specified, for example, the prudent insurer test would require that the age specified in the basic package be lowered. 3. Clinton's healthcare plan failed, and conventional political wisdom now holds that no healthcare reform even approaching the scope of that plan will be adopted in the United States for at least a generation. If that is true, our national disgrace will continue. It is disgraceful that so prosperous a nation cannot guarantee even a decent minimum of medical care to all those over whom it exercises dominion. Clinton's plan was, in retrospect, too complex, in some respects ill-judged, and in any case artlessly presented. But some of the plan's most forceful opponents argued, not just that the scheme was wrong in detail or even in design, but that it was rooted in the unacceptable socialistic idea that government should watch over people from cradle to grave rather than allow them to take responsibility for themselves. If the argument of this chapter, and indeed of this book as a whole, is sound, then this objection is wholly misguided. A community that is committed to equality of resources, so that people can make their own decisions about what lives are best for them, enforces rather than subverts proper principles of individual responsibility. It does accept that the intervention of government is sometimes necessary to provide the circumstances in which it is fair to ask all citizens to take responsibility for their own lives. but it respects the personal judgments of need and value that citizens have actually made or would be likely to make under appropriate conditions in the exercise of this responsibility. That goal is at the heart of the resource conception of equality and of the hypothetical insurance strategy it recommends. A healthcare scheme constructed to respect the decisions of citizens as prudent insurers is indeed egalitarian, but it is the very opposite of paternalistic.